Friends, I'm happy to be here today to share my thoughts about challenges and barriers on achieving nutrition in critical care. I've added something to the title. I'm going to talk about solutions too. And these solutions are practical in India and in Asian countries. And this is based on my experience in actually working in India, in Chennai, for several years and what I'm about to tell you is not particularly useful only in other countries, but also doable in India. I've given you my email address, so if you write to me, I'll be happy to share my slides and other references with you. And during the short time available to me, I'm going to talk about defining malnutrition, the importance of teamwork, empowering nurses and dietitians. How do we make physicians adhere to guidelines? Emphasis on early enteral feeding and dispelling myths, and limit the use of parenteral nutrition to specific strong indications, the importance of micronutrients, and the importance of nutrition in the continuum of care, pre-admission to post-discharge. I have no disclosures pertinent to this presentation, and all statements that I make here will be supported by references in peer-reviewed journals or major society guidelines. Patients don't die in a hospital and don't develop morbidity because of physician errors, but due to system failures. And a system failure in many hospitals is that nutrition itself is neglected. And the opinion of nurses and dietitians, who in many instances are more knowledgeable in nutrition than physicians, is not respected. And I'm going to address this during the course of my presentation. We all say that we need guidelines, and by guidelines, I mean guidelines by reputable societies. Unfortunately, a lot of folks in many Asian countries form societies with the help of the industry, and the societies start promoting products rather than actual genuine principles of medical practice. And when you take a guidelines, we have to make sure that the guidelines are adhered to. But there are various reasons, various steps that are needed to make sure that adherence will be good. For example, we should look at the guideline characteristics and make sure it is pertinent to that specific geographic area. The process of implementation takes time. Look at all the institutional characteristics. What is the ICU structure? Is it an open ICU or closed ICU? And what actually should the provider's intent be? In other words, how do we change their attitudes? How do we change their knowledge base? How do we change their motivation? And how do we make sure that the provider, in this case, mostly the physician, has an accountability in making sure that guidelines are actually practiced? And here is a study which was done in Australia, where they looked at the reasons why there are barriers to change. And this is specifically about the old-fashioned practice of keeping patients nil by mouth after midnight for a procedure to be done late afternoon the next day. And we know that many societies have said that solid food can be given 6 hours prior to a major procedure or general anesthesia, and liquids can be given 2 hours prior to surgical procedures. But why do physicians still hesitate in doing this? The major barriers seem to be cultural concerns and gaps in knowledge. And we do hope that conferences like this will decrease the gap in knowledge. The first problem we face with is defining malnutrition. Now, there is a confusion as to what actually malnutrition means, and there's a disconnect between various professionals. Please also remember that if you have a patient with hepatitis and you decide not to treat it, that's medical malpractice. The reason why malnutrition has been neglected is because the definition of malnutrition itself is very vague. And to make it easy, the Global Leadership Initiative on Malnutrition defined malnutrition in easier words using etiologic criteria, such as inflammation or disease burden, and phenotypic criteria, which is the traditional way of making a diagnosis of malnutrition. And if we have one of each, you have a diagnosis of malnutrition. And the advantages of this are that it was prepared by an international consortium, it standardizes malnutrition, and the 2022 American Society for Parenteral and Nutrition Guidelines clearly states that all publications in future must be using the GLIM criteria. I would urge the audience to practice this, at least in at the same time as the other methods of nutritional assessment we use. In due course, the GLIM criteria will be the only way by which malnutrition is diagnosed. So once you have made a diagnosis of malnutrition, then you got to treat it. GLIM has been compared to subjective global assessment, and there is a very good sensitivity and and specificity for diagnosing malnutrition using the GLIM criteria as compared to the subjective global assessment. When it comes to nutritional assessment, laboratory tests are not needed to diagnose malnutrition. The traditional visceral proteins are of absolutely no use. Albumin, pre-albumin, transferrin should not be used as a nutritional marker. And this is very clearly stated in various guidelines, including the 2021 Aspen position paper. It is true that a low level of albumin is a marker of stress response and inflammation, but not to diagnose malnutrition. And just because the albumin level is normal does not mean that malnutrition does not exist. If you want to check for stress, then there are other tests available like C-reactive protein and a high glucose level or leukocytosis, but not to diagnose malnutrition. And a major problem that I have noticed is physicians using albumin as a marker of malnutrition and then giving albumin to correct malnutrition and to rapidly correct it. Nothing could be further from the truth. And here is the Aspen position paper indicating that serum albumin and pre-albumin are not components of currently accepted definitions of malnutrition. Now, early enteral feeding is preferred because it maintains the GI tract integrity and it supports gut and mucosal associated lymphoid tissue, preserves the gut microbiota, and it prevents the abuse of parenteral nutrition. But there are several common objections to early enteral feeding as listed on this slide, which I will go through over the subsequent slides. High gastric residual volume, ileus, patient will not eat, or diarrhea, which is always blamed on enteral feeding, or the patient is hemodynamically unstable. Now, it is true there are various reasons why there may be a problem with GI intolerance and GI dysfunction in critically ill patients as listed on the slide, and a paper that just got published in Current Opinions in Critical Care. It is absolutely true. There are various reasons. But if you follow certain guidelines, then those reasons can be actually overcome. For example, if you take gastric residual volume, there is no relationship between gastric residual volume, organ failure, and mortality. And actually, publications have shown that there is no reason to measure it. And a gastric residual volume of 500 cc's can be used. So you need not use GRV as a part of routine management, and this itself will increase your use of enteral nutrition in ICU patients. And here is a paper in a community hospital in over 60 patients where there was no effect in adverse effects when GRV measurements were eliminated in a community teaching hospital. Another problem we have are mainly with surgeons who think that just because a gastrointestinal anastomosis was made at surgery, enteral feeding is contraindicated. Absolutely no evidence to show that. And in fact, in many hospitals, even after major procedures like pancreatic surgery, the patient is given a liquid diet in the same evening. Anastomosis heal better with early feeding. And feeding does not mean a huge meal, a regular huge meal. It means 500 cc's of an enteral formula. Another problem in critical care is the blood pressure. Nothing is further from the truth for physicians to say that the patient's blood pressure is not normal, therefore we should not use enteral feeding. You can withhold enteral feeding if the mean arterial pressure is less than 50 millimeter, is less than 50 millimeters of mercury, or when there are escalating doses of catecholamines, but there is no reason to actually limit the feeding. Trophic feedings at very slow doses can be used. And these are conditions where gastric residual volume can be used as a surrogate marker, and serum lactate levels can be used as a surrogate marker for intolerance of enteral feeding in hypotensive states. During the COVID crisis, we have seen a lot about prone positioning in COVID patients. And here are various papers to show that enteral feeding is absolutely safe in prone position, including a paper from India. Enteral feeding with ECMO has also been shown to be absolutely doable. Concentrated formulas at trophic feeding rates, at slow rates, and even permissive underfeeding may be acceptable. But remember that ECMO is not a contraindication for early feeding. So as you can see in several of these points that I made earlier, that in the majority of patients in the intensive care, enteral feeding can be used. Now we go to energy intake. This is a major difference during the last year. The 2022 guidelines that were just published about a month ago clearly states that energy requirements do not require predictive formulas, but the energy requirements are now decreased to 12 to 25 kilocalories per ideal body weight in the first 7 to 10 days. And we do not need expensive measurements like indirect calorimetry. It is only in the rare condition where the patient is severely malnourished where you might actually increase the energy requirement, or you may use parenteral nutrition to supplement it. When higher protein requirements are met, survival is the same whether you use hypocaloric or eucaloric measurements. But when you look at protein requirements, the guidelines have not changed at all, because the studies are inconclusive, and therefore 1.2 to 2 grams per kilogram of actual body weight is used. No evidence of association with subsequent renal insufficiency, so don't let anybody try to tell you that protein must be restricted because kidney failure will occur or because the patient may need to be dialyzed sooner. And there is, of course, evidence to show that in the first couple of days, the first 3 or 5 days, protein requirement is kept low and then gradually increase. But this again coincides with the gradual increase in calories. Start very low and then gradually increase it. And this is the way you can prevent refeeding syndrome. You have enough time to maintain electrolyte levels at normal levels. You have time to maintain the glucose levels. You replete vitamins and micronutrients and also thiamine. According to the patient's tolerance and conditions, gradually increase it. But there are other strategies to increase tolerance, using epidural anesthesia, maintaining the serum glucose levels, and the preemptive use of prokinetics and limiting the use of systemic narcotics will all help to increase tolerance to enteral feeding, because enteral feeding is the only known way by which protein catabolism can be minimized in the intensive care. Don't ever forget micronutrients, which includes vitamins and trace elements. They are deficiencies in the ICU are common, but they're not recognized. You don't need to use lab testing. And the 22 guidelines also clearly states that they must be an integral part of nutrition therapy. Enteral formulas contain sufficient amounts of micronutrients in bioavailable forms, but when you use parenteral nutrition, you must give it parenterally too. All trace elements and multivitamins must be given parenterally. And here are some newer opinions saying that in the first few days when enteral feeding is progress and it takes several days, please give intravenous or oral or enteral micronutrients. The term includes both trace elements as well as multivitamins. And in the first 2 or 3 days, extra doses of thiamine, 100 to 200 milligrams per day, is also now recommended. Now, when you come to the choice of enteral products, there is a myth indicating that blenderized kitchen-prepared diets are safe and cheap for use in critically ill patients. Nothing is further from the truth. Blenderized kitchen-prepared diets have unknown osmolality. The nutritional content is unknown, however good the dietitians may be. But the main reason is poor microbial quality. And if Many studies have shown that in 4 hours after the kitchen prepared diet leaves the kitchen and goes to the intensive care, the microbial quality is so poor that if this was a restaurant, the government would close it. And yet we do it in a hospital. And so we should abandon the use of blenderized kitchen prepared diets in all hospitalized patients, especially in the intensive care. And of course, administrators seem to think it is cheaper, but several smaller studies have shown clearly that if you take the cost of procurement, the labor involved, the wastage, kitchen prepared diets are actually more expensive to the hospital and to patients. And in many places, the enteral formulas are routed through the pharmacy rather than the kitchen. And many insurance companies are also beginning to pay for it. But there is absolutely no use to use peptide-based or elemental formulas, not even in jejunostomy patients. Use the standard formulas. Do not use hepatic or pulmonary formulas. And only on a case-by-case basis, renal failure, diabetes, or stress-induced hyperglycemia may require the use of specialized formulas. This itself will cut down your barrier to appropriate use of enteral formulas in intensive care unit patients. And here is a study just published about 2 weeks ago showing that polymeric enteral formulas exclusively used is well tolerated and safe even in patients with Crohn's disease. And this was an Australian study on 66 patients with 6 days duration. We should not forget about continuum of care. From the pre-admission time, nutritional assessment is done 10 days prior to any planned admission to surgery or any planned admission to the intensive care. This is a time to correct drug-nutrient interactions, to look at the fluid balance and correct the electrolytes. A nutritionist's approval for major surgery is as important as cardiology or anesthesiology clearance. And this itself will increase your tolerance in the intensive care to early enteral feeding, which is one of the best known modalities to cut down morbidity and mortality. And the ERAS protocol, the Enhanced Recovery After Surgery, looks at pre-admission, at the clinics, pre-op, post-op, and at home, and a 30-day follow-up. And for this, you need an interactive team. There are several components of the ERAS protocol, as seen on the slide. A lot of those are dependent upon early nutrition. So I would urge all of you to encourage your surgeons and anesthesiologists to follow the Enhanced Recovery After Surgery protocols to decrease morbidity in the intensive care. Parenteral nutrition is used only when there are total and absolute contraindications to enteral feeding, such as total bowel obstruction or fistulas or intra-abdominal hypertension, terminally ill patients. Otherwise, enteral feeding can be used in the majority of patients. Supplemental parenteral nutrition can be used only when the goal is not achieved in about 5 days. The American guidelines say 7 days. The European guidelines say 3 days. The truth is somewhere in between. And here is a study to show that a team approach will cut down the inappropriate parenteral nutrition. It was a study I published some years ago, which takes me to the last part of my presentation about teamwork and empowering nurses and dietitians. A nutrition support team is very, very important for making sure that intensive care unit patients are able to receive the proper nutrition. They look at the lab tests, they review the catheter, feeding tubes, review the indications, and they communicate with the primary team taking care of the patient. The 2018 standards published by the American Society of Parenteral Nutrition states very clearly that different hospitals may have different definitions of a team. But even if no team is available, an interprofessional approach is used. Here is a study saying that interdisciplinary teamwork is absolutely important in intensive care units, and dietitians play a crucial role. Nutritional goals are reached faster. And gone are the days when the physicians think that they are the leader. We should have a situation where dietitians and nurses are respected, and they will help you to preserve muscle strength in intensive care unit patients. A patient-centric approach is best facilitated by nurses and by dietitians. And here is a publication that is due to be published very soon, accepted in Critical Care Medicine, co-authored with me. by Gail Cresci, who is the present president of the American Society. The dietitian is the most knowledgeable member of the interprofessional healthcare team with respect to identification of malnutrition, macro and micronutrient, and the type of nutrition therapy, and they must be recognized more. My concluding remarks are, we should use the 6 principles of nutritional care to design the process change, create an institutional culture, recognize nutrition early, rapid implementation, plan discharge, and have an accountability for proper nutrition care. Avoid physician-directed malnutrition. Don't keep patients on clear liquids when there is no reason at all, and slow advance of diet. And to change it, you need to get other physicians and especially hospital administrators to understand the importance of nutrition practices. Thank you very much.